Next lecture we're going to go through is capnography, and one, it's part of the, again, these are all requirements for the National Registry, and kind of understanding it and why we use it and when we use it. So, capnography, why do we use it? Your CO2, which is what you're picking up, reflects your ventilation. You'll detect apnea and hypoventilation immediately, and should be used in conjunction with pulse oximetry. Your O2 sat will reflect your oxygenation, where your CO2 monitor is reflecting your ventilation. Your O2 sat is going to lag 30 to 60 seconds behind apnea or hypoventilation, which is why we use CO2 monitoring in procedural sedation, because you'll pick up a change in that when they're too deeply sedated and apneic before your pulse oximetry is going to drop. So these get used in conjunction. Your capnography and your oxygen saturation are kind of hand in hand. So indications for use of end-tidal CO2 monitoring: to validate proper tube placement after endotracheal intubation, detection and monitoring for respiratory depression, hypoventilation, obstructive sleep apneic patients, procedural sedation like I talked about in the ER, and adjustments in your parameter settings in vented patients. We have a whole event lecture we'll go through later. Your end tidal in codes, basically non-survivors were below 10. 4 to 10, they did not survive. Survived to leave the building, like actually walk out, be intact. Their end titles stayed above 30. So in that 10 to 30 range is when you got a lot of the survivors, but not narrow intact. And if they pretty much stayed below 10 with good CPR, they were not going to survive their code. So if a patient's intubated and pulmonary ventilation is consistent with bagging, your end tidal CO2 will directly reflect your cardiac output. So the big thing is, do you have good airway management first? Because if your airway's not appropriate, you're not going to be picking up an accurate end tidal. So if you see big changes in your end tidal CO2, either a drop or an increase, you need to look at what's happening with the patient. So a flat waveform can establish PEA, not getting any cardiac output despite seeing a rhythm on the monitor. Or you're coding them, and your end tidal's 20, and your Lucas is in place, you're seeing 20, 20, 20, and all of a sudden you see 40 on the monitor. That might be where you need to pause and do a pulse check, because you likely have some return of circulation there. And your configuration will change if there's an obstruction. So all of a sudden your capnography looks different. You worry about, is there a big mucus plug or a big blood clot or something in your tube, or is your equipment obstructed? So what are we measuring? Kind of the big picture and why we see what we see on the monitor, the numbers in the waveform, is this is really looking at our cellular metabolism. Your cells take oxygen in, and they produce CO2. That CO2 leaves your cells and gets transported via our bloodstream into our pulmonary capillaries and diffusion into the alveoli, and then ventilation is we bring that CO2 out. So we are detecting what that CO2 at the cellular level is getting exhaled by the lungs. And that's why we see changes in this based on changes in our metabolism, heart rate, blood pressure. So that's the waveform you're looking at, and just another pictorial of that CO2 moving and why it shows up on your monitor and what it's looking at. So physiologic factors that affect our end tidal level. With increasing end tidal levels, you can see that with increasing muscular activity. Your cells are using more, so like shivering patients. So it can be seen in just normal cold patients or patients who are induced hypothermia that start shivering. You can see a rise in their end tidal. Malignant hyperthermia, again, increased metabolism in that cell. Increased cardiac output, so that's during resuscitation, all of a sudden you get more outputs and a return of pulse. You'll see an increase in that. If you give bicarb, or if you release a large tourniquet. So they've had not an IV start tourniquet, but you put one on their thigh for a big arterial bleed, and that gets released if they were on intubated at the time, and during that release, due to that cellular metabolism, all that lactic acid, and that whole cellular process, you'll see a transient increase in your end tidal. So kind of think about that if there's some big trauma patient that you've made some big change in that might change this blood flow to lots of tissues. It may not be your actual ventilation that's changed in it. You give, they're an asthmatic or COPD, and you give your neb, all of a sudden you see improvement in their end tidal. And decreased minute ventilation, so slower respiratory rate. Decrease in your end tidal can be due to decreased muscular activity. So the muscle relaxants, all those drugs we give for RSI, temporarily see a decrease in your end tidal. Your hypothermia patients, decreased cardiac output. So all of a sudden you had been coding a patient, you got them back, they had a pulse, you're bagging them, and all of a sudden your end tidal goes from 43 to 20 to 18. Better be checking a pulse because you've likely lost your pulse and they're in PEA, even though you have a rhythm on the monitor. A big PE, because they're not exchanging that, because that vessel is obstructed. Bronchospasm, so bad COPD or asthmatic, or increased minute ventilation. So those are those anxiety, hyperventilating, and you'll see a decrease in your end tidal. That's why they get tingly fingers. So your arterial, what you would get on a blood gas, correlates quite significantly with what we're seeing on our end tidal CO2 monitor. I had a patient just this last week that I was talking about. He had a PCO2 of 52 after we intubated him. His end tidal was 52 or 53. So very close correlation. And you can see that your PaCO2 on an ABG is 35 to 45, and your normal here is 30 to 43. So very similar values that you'll get. So it's a nice non-invasive way, without poking the patient, to get your end tidal. When you look at a vented patient, you have to add in your dead space and think of increasing your volume to accommodate for that. So all of your airway, your large airways, those are dead space. There's no gas exchange going on there. They're just a pathway to get there. In your alveoli, you have areas where there's no blood flow, so that's dead space. And then all your vent or your CPAP, all that is non-exchanged airway. So there's a complicated physics, basically, way of getting your reading. So it's kind of similar to your pulse ox, but there's a beam of infrared light that passes through a gas sample containing CO2. CO2 molecule absorbs a specific wavelength of that light, and light emerging from that sample is analyzed, and a ration of the CO2 affected turns into non-affected wavelengths and reported CO2. So that's kind of the fancy physics way of saying you get a number because of light being absorbed through that gas. And we have capnography versus capnometry. So your capnography is your nice waveform that you get, and you need to understand what is happening at each that we'll go through. And then this is just your number. So some monitors will give you both. Some monitors will only give you a number. So the capnography is a measurement of both your end tidal value and your waveform, called the capnograph. The capnometry is just that number. You're not going to see the waveform. So some of your smaller transport agencies you start to see a number that they get. They're cheaper rather than an actual waveform on there. And we have both. We have our mainstream and our intubated patients that you hook up to your ET tube and your vent, and we have the side stream, the little walruses that we put on the patients. So in your asthmatics, your COPDers, all your non-intubated patients, you're going to be doing side stream, and this is the same thing we put on for procedural sedation in all of our ER patients. Oh, really? We don't have like we have in the ER?
No, they're the
Mainstream. Okay. Okay, so I assumed, I guess, that the ones we put on were mainstream in the ambulance. Okay. Again, for some of you, I don't know if any of you in here are old enough to remember the little color changes that you put on when you intubated and they turned pink or purple or stayed yellow. So that was a quality of yes or no. Do you have end title change? Blank does? An actual capnography. Interesting. Yeah, because we don't even stock those color change things anymore. And yeah, those little NICU ones are teeny tiny. But old school, we still have some of those probably laying around at different places like peds. So your quantitative provides an actual number. It's going to be in all your capnographs and capnometers. And your qualitative is only that range of values of yes, it's changing, or no. We used to put it on after every tube. And they're termed the CO2 detectors. Is it there? Is it not, basically? And there was lots of false positives if you're in the esophagus for a short time, if there was food and all that stuff. So they got determined to not be as useful. It's a color change chemical that is, when it's exposed to CO2, it changes colors. It's kind of like a litmus paper type thought, but it's based on the CO2 exposure rather than a pH. And you need to make sure you have plenty of breaths in before you give a determination, because you can't put it in the esophagus and get a little CO2 initially, and then after a few breaths, that'll disappear. So, looking at the actual waveform in the capnogram, your bottom is beginning of exhalation, where alveolar gases mix with all that dead space, so all those large airways and any potential vent equipment hooked up. Then you get to where you actually get what the alveolar gases are being exhaled. End of expiration, right before your next inspiration breath. This is where your end tidal's measured from, right here, the end of expiration. So your capnogram provides ventilation of your end tidal, or validation of your end tidal, a visual assessment of a patient airway, verification of your ET tube, and we'll show here in a bit what it looks like when it's in an esophagus, an assessment of your circuit integrity of your ventilator and your breathing circuit. Looking at the different phases, kind of what I went through, A is your baseline, A to B, that kind of flat. That's your inhalation and sitting there before you exhale. This is kind of that fast beginning to exhalation, and then D is maximum expiratory of all your gases right before you take your next inspiration. So, again, looking at that, that's what you're looking for, is where your peak is. This is what it's going to look like if you tube the esophagus. Get a little bit initially, and then you don't get any respiratory waveform, because it's just air going into the belly and not exhaling. So if you see this after you think you've tubed but you haven't seen it gone through the cords, you just thought it did, better be pulling that pretty quick. If you have an inadequate seal around the tube, or maybe you put in too small of an airway, your partner handed you a 5.0 instead of an 8.0 tube, this is kind of your waveform you can get, because not enough exhalation and mixing of gases, so really short upstroke and exhaling slowly there. So hypoventilation. So a decrease in your respiratory rate, decrease in your tidal volume, not taking in big breaths, increase in metabolic rate. All of a sudden, they need more energy, or you have return of your perfusion if their CO2 is clear down here, in the 10-20s, and all of a sudden now it's up here, versus it was at normal and now it's increasing. Or rapid rise in body temperature. They were hypothermic and you started warming them from a drowning, and all of a sudden they go from down here, getting up because they're producing, and those vessels are being perfused, and they're producing their end tidal. So it's a rapid change in their metabolic rate, essentially, is what change in body temperature is. If they're hyperventilating, so increasing your respiratory rate or an increase in your tidal volume, your anxiety patients, that's this increase in respiratory rate. They may not be taking in much. Sometimes they are. Other times they're just fast, and you can see their CO2 ticking down because they're blowing off so much, and then all of a sudden they get their carpal pedal spasms and they freak out more. So it's a nice reassuring way when they say, oh, I'm asthmatic, and you really think they're having an anxiety attack. That's a nice way to put that on and see that response on them. And then a sudden fall in their temperature or gradual because you've induced, they were hyperthermic and you've cooled them off. Rebreathing. Couple causes that can lead to that is your expiratory valve on your vent isn't working appropriately. You have inadequate inspiratory flow or insufficient expiratory flow. So this is where you can kind of see that breath stacking. You never get completely exhaled. So at rest, you still have more CO2. You're not getting rid of all of it. So you're rebreathing that CO2 in and in. So this is what you can start to see, and it'll get more pronounced with this baseline, this kind of A to B that was on that previous slide, elevated more and more and more in a COPDer who's not being allowed to exhale enough or not getting enough exhalation phase out. They stack up, and it's kind of that auto PEEP response. So this is that kind of shark fin look. You can be an obstruction in your tubing if you don't think they're a COPD or asthmatic, that you kinked off your tubing or you have a plug, a foreign body, or a mucus plug in there. But you can also get kind of that big upstroke, pointed look, and a asthmatic because they're forcing out more air and it's not a quick, they need more time to exhale. So it's taking longer to get up to that peak. And it looks kind of like this, have a high, and it's not that nice gradual here. They call that the shark fin look or a little tail on it. So that'll be what a lot of your obstructive patterns look like, your asthma or your COPD. Do you guys typically see this when you put it on a asthmatic or COPD, or do you really pay attention? Sometimes. And I don't know how true severe they have to be. I think every patient's probably different in their response and how much of their airways are having that arterial exchange. I thought this was kind of interesting that you may see after you do an RSI. It's called the curare cleft. My guess is you'll see it more in your rock and VEC than you will in your sucks, but when your muscle relaxants begin to subside, you see this little dip as they're kind of waking up. So if you see that, it can just be due to the fact that they had a paralytic and nothing that's wrong with your vent or their breathing pattern, but just kind of interesting thing that may show up sometimes. I've never seen it after RSI on somebody or anything, but it's there. A faulty ventilator circuit valve can be seen. Again, not getting completely back to baseline and gradually stacking. So your abnormal descending limb, your capnogram, and they are inhaling their exhaled gases, so not fully exhaling and then resting. If you have a sudden loss of waveform, obviously apnea, so that's what we're looking for in our procedural sedation patients. They just have no waveform seen. You have an airway obstruction, something's completely occluded, either their natural airway or their endotracheal tube. You've dislodged it. You thought it was in the esophagus, and especially if it's a peds, you don't have a cuff tube on. You're bagging them, you move them, and now all of a sudden you see this after you had them hooked up to the vent. Better check your airway placement, disconnection from your vent, or they've cardiac arrested in the middle of your resuscitation. So if you have a regular shaped waveform, but your plateau, so that top line, that kind of C to D on that previous pictogram, is below normal, that indicates a CO2 deficiency, low CO2. So they're hyperventilating, they have decreased pulmonary perfusion, so can have PE, something's not going to that pulmonary arteries. They're cold, or they have decreased metabolism, which would be seen in anything that's been given to slow rate down. So you can increase their ventilatory rate, evaluate for adequate sedation, evaluate, are they anxious? Do they need benzos to slow their breathing rate down? And help conserve their body heat if they're drowning cold exposure victim. So now if your plateau is above the normal range, then they're hypoventilating. They've had respiratory depressant drugs on board, fast metabolism, they're on, you think about that if you've given them, or if they've taken any kind of stimulant drug, meth, PCP, all of those are going to have a high metabolism, or they're shivering, they have a fever. So again, adjust their ventilation rate, decrease the depressant drug dosages so they're not so sedated, assess pain management, and conserve their body heat. So that one's pretty short. We'll get into more of how you adjust those on the vent in our ventilation lecture. Questions? You guys are all ready for lunch. All right.